Yes, I'm Dr. Holt, going to address non-surgical treatment options of osteoarthritis. Kind of one of the most common questions I get in clinic. I'm a hand and upper extremity surgeon, do primarily kind of elbow, wrist, hand, finger surgery. I'm trying to make this fairly broad and generic, so some of this will be specific to, specific joints, knees, hips, hands, but most of the information trying to be as general as I can of essentially how to manage and treat arthritis before surgical options. So what is arthritis? At its base, it is inflamed, swollen joints that generally lead to pain and stiffness. And that's a very generic term for arthritis in general. There are classically kind of two types of arthritis. One is inflammatory arthritis, and these are chronic autoimmune type diseases, rheumatoid arthritis, lupus, psoriatic arthritis, even gout gets kind of thrown into this category. Not always, but these often start at a younger age, and they can often affect other organs based on their kind of autoimmune etiology, including sometimes heart, lungs, skin, etc. So osteoarthritis is what most people, when they think of or talk about arthritis or say, hey, I have arthritis, generally we're talking about osteoarthritis. It's certainly the more common. It's degeneration of the cartilage and underlying the bone. We see here on the left picture a healthy joint where this kind of thin blue line is the kind of semi-soft, smooth layer on the edge of the bone, which is the cartilage. And over time, that starts to degenerate, and that's osteoarthritis. It's classically thought of as wear and tear, that over time it happens and that cartilage wears out, the joint wears out, and that leads to symptoms. Other common causes are post-traumatic, after a previous injury. We're also learning more and more, which we'll talk about some, that there are probably genetic predispositions as well as inflammatory. And so some of these categories overlap. But again, in general, we think of arthritis as two main categories, the inflammatory versus osteoarthritis, which is the more common and which we'll focus on today. So covering that just a little bit more. So, inflammatory arthritis, the classic thought is that it's an autoimmune disease where your body's immune system is attacking your joints, which leads to inflammation, which leads to a worn out joint and pain. Where osteoarthritis is somewhat the reverse. Classically, we've thought of it as wear and tear leads to a worn out joint, which then because of the kind of wearing of the joint, then it leads to inflammation. I think what people are finding more and more that do a lot of research on arthritis and getting a better understanding is that even the osteoarthritis, the classic wear and tear arthritis, is a lot more complicated. Certainly there's an element of wear and tear, but we also think that it is inflammatory related as well. Also mentioned the genetics, trauma, there can be other potential etiologies, but inflammation is a lot bigger part in the kind of cause and symptoms than just wear and tear, even for osteoarthritis. And that gets into a lot of the treatment options. So osteoarthritis is super common and becoming more common. In the US, approximately 18% of women and 10% of men over the age of 60 have symptomatic osteoarthritis. Probably quite a higher percentage have it on radiographs, but maybe asymptomatic or will develop symptoms at a later age. So it's estimated that by 2050, up to 150 million people in the US may have osteoarthritis. We're seeing an increasing incidence in younger patients. Not entirely sure why, but we're seeing any younger patients than in the past. Estimated total medical cost, 130 billion. That was several years ago, so it's only increased since that time. So how do we diagnose osteoarthritis? Number one is based on radiographs. So I'll take you through a couple here of multiple joints. Here's a knee joint. We see the kind of two main compartments of the knee. One is the lateral compartment. There's a good space between those two. That's the cartilage that doesn't show up on an x-ray picture. We go over to the inside or the medial compartment, and this is the, what we call bone-on-bone arthritis. There's loss of joint space. The bone is kind of thickened through there, and it doesn't have that nice smooth space between the two bones. Here's a hip. On this side, which is the right side of the hip, we see all that bright white, which is thickened sclerotic bone. We see these kind of beaks at the edge of the bone, which are osteophytes, or what we call bone spurs. The space between the two bones, the ball of the femur and the socket, or what we call the acetabulum, most of that space has kind of gone away, and that's easily compared to the opposite side, where there's probably a little bit of arthritic changes. We see some small bone spurs, but overall pretty good joint space, fairly much better looking hip. So here's the base of the thumb, which I commonly treat. One of the most common type of arthritis is that I treat. This is the large bone of the thumb, what we call the metacarpal. coming down to one of the small wrist bones called the trapezium. And same thing, we see loss of joint space. So the cartilages start to wear away or degenerate. So the bones now are rubbing on each other without that nice padding between them. This large thing here is a large osteophyte. We compare that to the next joint down, where it's nice and smooth, nice space between the two joints. Similarly, fingers, we see a lot of arthritis at the last joint of the finger, what we call the DIP joint. Here's a nice healthy one, nice and smooth, good space. We come over to this one, can hardly even see a joint at all. And that's manifested outwardly, which is very common. People get these osteophytes or small bumps over the back of their finger, which is consistent with these bone spurs that we see on the x-ray picture. So that's how we diagnose it, based on x-ray pictures put together with symptoms. Again, we won't touch too much on the inflammatory type arthritis, but things like rheumatoid arthritis, lupus, etc., generally are diagnosed more by a rheumatologist based on x-ray symptoms, but also laboratory workup. So for osteoarthritis, we know there are some risk factors that are potentially modifiable or preventable. Certainly trauma. We see a bad knee injury here on the picture on the right. We know that severe trauma to joints puts people at a much higher risk of developing post-traumatic arthritis, even when treated surgically, or potentially even when treated surgically. We know obesity puts patients at a higher risk of developing osteoarthritis. We believe that repetition, high impact can as well. Potential, whether that's occupation or sports, but potentially high impact type repetition activities may put people at a higher risk. Kind of tying into the obesity, we also believe that metabolic syndrome can put patients at a higher risk of developing osteoarthritis. Some non-modifiable factors below. Osteoarthritis is more common in females than males, certainly more common as we age. As I touched on before, there's certainly a genetic component and also a racial component, where it can be variable prevalence in different races. And the other thing, which we'll kind of touch on more through treatment, is this inflammation. As we're understanding more and more that even osteoarthritis has an inflammatory component, is that the end result in just we are trying to treat the arthritis, or can we actually potentially prevent it by modifying or limiting inflammation throughout our lives? And there's not a good answer for that yet, but I think there's more and more thought that potentially limiting inflammation may decrease the risk of developing osteoarthritis long term. So non-surgical treatment, we'll run through these, and these are very kind of classic non-surgical treatment options. What we call the Nsaids, which are anti-inflammatory medications, kind of a list there. Exercise, physical therapy, weight loss, corticosteroid injections, certainly surgery. Additional ones we'll run through. There are some potential dietary modifications and supplements that can help. We'll kind of touch on stem cell therapy and a few other things as well. I'm going to try to focus on things that have a reasonable amount of research behind them, either good or bad, so that we can come up with a fairly good judgment of whether or not they work. Our job as physicians is to use evidence-based medicine. That's a term that gets talked about a lot, but what that means is that we take research that's been done on various patients, arthritis, different joints, etc., various treatment options. We put that together with what the patient wants, what individual patients, what their goals are, whether it's pain relief, functional improvement, and together with our expertise, kind of put that all together to try to make a decision with the patient based on evidence-based medicine. So for osteoarthritis, general treatment goals are going to be symptomatic management, trying to decrease a patient's pain, and also functional improvement. I put down there, as far as we know, no real study or literature has shown that we can reverse osteoarthritis. We do think we can manage it and limit some of the side effects, but at least at this point, there's no clear way or known way to truly reverse osteoarthritis. So anti-inflammatories, classic treatment. These are the Nsaids, or what are called non-steroidal anti-inflammatory drugs. Over-the-counter options such as Advil and naproxen. There are multiple prescriptions. Some of the most common are meloxicam and Celebrex, as well as Diclofenac, which can be done topical or orally. Generally considered first-line treatment. That being said, there are some serious adverse reactions or contraindications. Anybody that's on an anticoagulant or blood thinner generally cannot take Nsaids, or at least should certainly check with their primary care provider. These can cause GI ulcers or GI bleeds, or often just GI distress. Many people can manage that. Some of the prescription medications like meloxicam and Celebrex are designed to be easier on the stomach, but can still cause some GI problems. They're also processed by your kidneys. So anybody with renal or kidney disease, has to be very careful and potentially limit use completely of anti-inflammatories. The picture here is of topical diclofenac or Voltaren gel. I recommend this to a lot of patients. I get really mixed results, and I'll tell patients that. For some people, it's fantastic, can really help manage arthritic pain. Some patients kind of get little to no relief out of it, but I think it's a very safe, easy option. Topical, doesn't have the systemic or potential side effects that can often help out and manage quite a bit of arthritic pain. Used to be prescriptions, now actually over the counter, so you can pick this up anytime. Sometimes depending on your insurance, it can be a little cheaper if you purchase it over the counter or if you get a prescription and you use your insurance. So exercise and PT, I'll sometimes get pushback from patients or kind of questions about, hey, will therapy actually help my arthritis? And it can. It is certainly not going to change the wearing out of the joint that you have on the x-rays. It's not going to reverse it or regrow your cartilage, but multiple studies have shown and evidence shows that potentially certain exercises and therapy can help you have less pain and more function. And this really kind of varies depending on the specific joint, whether we're talking knee arthritis or hip arthritis or maybe thumb arthritis. But for instance, with knee arthritis, we know that strengthening your quad muscle, the big muscle in the front of your thigh, can help take off or decrease some of the stress on your knee. Focused stretching can certainly help. Tight muscles can be more painful and lead to more symptomatic arthritis. Balance training, low impact exercise generally is good and good for kind of health overall. Exercises such as walking, swimming, bicycling, yoga, Pilates, Tai Chi, a lot of these have been shown to help limit arthritic symptoms and keep people functional and healthy. So here's just one study out of New England Journal of Medicine where they compared physical therapy to corticosteroid injections. So 156 patients, half received dedicated therapy, half received a corticosteroid or what we call a glucocorticoid injection. And the numbers down here basically show how well people did. So all of them started with a pain level or a score of about 107 or 108. High numbers bad, low numbers good. And with therapy, they dropped from 107 to 37. And with a steroid injection from 108 to 55, 56. So in this case, patients with PT had less pain and disability after 1 year than those who received a steroid injection. So I think it's something to think about and can be very effective for many patients, even though it's understandably a lot of people have some concern about trying therapy for arthritis. I think it can actually provide good pain relief and potentially functional improvement. Bracing, here I showed a couple examples of some CMC braces. I have a lot of patients that get a ton of symptomatic relief when they wear a brace. Essentially stabilizing the base of the thumb can reduce the stress on that joint and help patients attain much more function and pain relief. Generally not a long-term fix, but many patients will use these for years and years, certainly with activities that are going to be more prone to cause symptoms or pain and be able to manage the pain quite well with functional kind of joint-specific bracing. So injections, I'll kind of focus on corticosteroid injections. The generic term is cortisone. A lot of people come in, we talk about cortisone injections. Our recommendations really vary. You know, I looked at various recommendations from different basically orthopedic societies, including in the US and overseas in Europe. Some kind of strongly recommend corticosteroid injections, some recommend against. I think in general, my experience and based on research is that most patients, and what I tell them, get short-term pain relief. So with an injection for arthritis, most patients are going to get some pain relief for some period of time. It does have the potential for kind of exacerbating the cartilage and joint damage. I think in general, having an injection or two is safe. And if it provides the patient significant long-term relief, then probably the benefits outweigh the risks. But certainly doing a lot of injections or repeated injections, we worry can potentially advance or even worsen your arthritis long-term. It is smart to avoid these close to surgery. We know it can kind of place patients at a slightly higher risk of infection if you get a corticosteroid injection right around the time of a surgery on the same joint. Side effects overall pretty rare, or at least serious side effects are pretty uncommon. Often patients get a little steroid flare, transient increased pain at the site of the injection. Extremely rare is to get an infection or serious adverse reaction. One thing certainly to think about in diabetics, we do know that corticosteroid injections can affect your blood sugar. Usually it's about a 3 to 5 day increase. In general, if patients are pretty well controlled, it's not too concerning, but certainly poorly controlled diabetics need to carefully consider whether or not to proceed with an injection and potentially avoid them. The big question we always get is how many and how often, and we don't have an answer. There's not a lot of great studies that kind of will tell people or tell us how many or how often patients should get. I think most of us tell people, you know, probably every 3 to 4 months. Probably shouldn't do too much more frequently with that. As I mentioned, certainly wouldn't want to limit injections around the time of surgery. Many people suggest waiting at least 90 days between an injection and a surgery. Some of that depends on the specifics of the surgery. How often? In general, I feel, you know, if patients are starting to require them every 3 to 4 months and the relief is starting to decrease, they're probably doing that for about a year or so is enough. But there's no hard and fast rule, and I think that's something to talk about with your treating physician, and a lot of it just kind of depends on the relief you get, how much relief and how long, and what the alternatives are. So getting into weight loss and obesity, which is certainly a tough topic, and even as we know and many patients know, it can help out our arthritic symptoms and pain. Of course, it's hard to do, and that's the challenge. But I think it's worth touching on. The classic thought, again, back to the wear and tear for osteoarthritis, is just logical that increased weight is going to cause more force, more wear and tear on a joint, and certainly there is some element of that. I think that we are also learning that obesity and especially morbidly obese really can create its own kind of inflammatory reaction in the body. We know that obesity increases inflammation in the body. This metabolic syndrome, which is kind of a combination of obesity and diabetes, has thought to potentially directly lead to osteoarthritis, even without other potential risk factors such as trauma or genetics. Studies have shown that decreasing weight 10% leads to approximately 50% decrease in knee pain. There are also some suggestion that potentially weight reduction may actually reduce the risk of knee osteoarthritis. And that's still kind of an unknown. I think we are still trying to learn, again, the effects on inflammation and risk of arthritis, limiting the risk of arthritis, and how obesity and weight comes into all of that. But certainly without a doubt, we know that obesity causes increased inflammation, and it seems like increasing inflammation puts you at a higher risk of developing arthritis, and certainly more symptomatic arthritis if you have arthritis. So just to touch briefly on stem cells, I get a lot of questions about these, you know, and there's a lot of advertisements out there that are kind of directly marketed to patients. Stem cells, you know, are kind of relatively new, at least in treatment for joint pain and joint pathology and osteoarthritis. At this point, they're not FDA approved, so vast majority of insurances will not pay for stem cell treatment. It's generally cash only. It's generally very expensive. There's a lot of inconsistency in the type and preparation, and when you hear a provider or a patient or an advertisement say stem cell, it doesn't always mean the same thing from one kind of product to another. At this point, there's no consistent data demonstrating improvement, and there are potential serious complications. Due to that kind of inconsistency in type and preparation, there's been reports of serious infections, reports of seizures. I'm hopeful that someday that we are able to learn more and develop these kind of more targeted and more specific, and that they'll ultimately be a good option for patients. But I think at this point, the data is not there. The risks are maybe a little bit too high, and I think in general, patients should avoid them. Glucosamine and Chondroitin, these are a supplement, an oral supplement. They are natural compounds found in the cartilage that are protective and anti-inflammatory. So the thought has been to potentially take them as an oral supplement to help decrease the inflammation, as well as provide some precursors to the cartilage to hopefully protect and limit cartilage degeneration. Question about efficacy. One study looked at 1,600 patients. Early results back in 2006 basically showed significant benefit for moderate to severe knee arthritis. A follow-up in 2010, kind of longer-term follow-up, showed that it was no better than Celebrex, which is an oral NSAID or anti-inflammatory, or a placebo. Placebo means no treatment at all. Another study in 2015 showed that it was relatively equal to Celebrex for overall knee pain and swelling. Generally, I think they're safe. They can interact with an anticoagulant or certain anticoagulants if you're on warfarin. So in general, I think they are safe, potentially beneficial. I think they're a little more popular in Europe and some other countries who kind of recommended them as first-line treatment, even potentially over NSAIDs like ibuprofen, Celebrex, etc. Here, we don't quite recommend quite as much, but I think they are potentially beneficial and generally safe. Diet and nutrition, even aside from weight and obesity, does diet matter? And we think so, kind of more and more in line with the inflammatory type thinking of osteoarthritis. Certainly there's a wear and tear component, but we also think there's an inflammatory component. Potential that pro-inflammatory diets, certain diets that increase inflammation in your diet, or in your body, excuse me, may lead to just low-grade systemic inflammation, which may put patients at a higher risk of developing arthritis, or certainly if someone has osteoarthritis, making those symptoms worse. You know, I put question marks to these because I think we are still trying to figure this out, and nutritional studies are kind of notoriously difficult. You'll often find studies that contradict each other. In general, I think the thought is that, you know, animal products, especially red meat, dairy products, highly processed foods are going to be more inflammatory or pro-inflammatory and cause inflammation in the body. Whereas in general, more whole foods, whole grains, vegetables, fruit, legumes, beans, and nuts are going to be less inflammatory and potentially anti-inflammatory. But that's not always necessarily a hard line, and some of these things we're still trying to kind of figure out their effect. There are good studies on a couple of herbal supplements. First I'll touch on is turmeric. Turmeric is just a spice. Many people can add it to food, teas. You can also get it as a supplement such as a vitamin. Fairly good studies for knee osteoarthritis when they compare turmeric versus ibuprofen or an over-the-counter NSAID. Turmeric showed increased walking distance, less pain, and less adverse effects. People ask about the dose. Most of the studies seem to suggest about 1,000 milligrams a day. It can cause mild GI distress, but generally not to the degree of taking an anti-inflammatory like an ibuprofen. And it's also an anticoagulant, so need to be careful if you're on an anticoagulant already, such as warfarin or another medication. Ginger, similar herb. It's been used for a long time in Asian kind of musculoskeletal pain relief. Definitely has been shown to be anti-inflammatory. It has a mechanism very similar to Celebrex, which is one of our prescription anti-inflammatories, what is called COX-2 inhibition. It's been shown to reduce pain and reduce disability, potentially GI protective, so kind of similar to like a Celebrex type medication, but potentially even protective of your stomach and limiting ulcers or gastric bleeds. A lot of people don't like the taste. It can cause some GI distress, but more kind of discomfort and nausea as opposed to actual potential for like a GI bleed or ulcer. It is also an anticoagulant because it works very similar to our typical NSAIDs. So be careful if you're taking another blood thinner. Standard dose for a lot of the studies is 500 milligrams ginger extract. Again, you can use it as a spice, get a tea, or you can get an actual capsule or supplement. There's been some studies on the Mediterranean diet, getting back to kind of pro-inflammatory versus anti-inflammatory. In general, Mediterranean diet kind of focuses on whole foods, whole grains, fruits, vegetables, lots of legumes, extra virgin olive oil, low in red meat and dairy, but some. There are good studies that show this actually decreases the risk of rheumatoid arthritis, and that patients that are on a Mediterranean diet have a lower prevalence of osteoarthritis. So whether or not it actually decreases the risk of developing osteoarthritis is not known, but certainly it has been shown that people that are on this diet have an overall lower rate or prevalence of osteoarthritis and potentially can decrease overall inflammation in the body, decrease risks and symptoms. So those are kind of the non-surgical treatments that, you know, kind of the most common ones are the ones that I think have the best overall data, either good or bad, to make a pretty good statement on. And again, a lot of these are all aimed at limiting inflammation, whether we are trying to limit inflammation on the front end to potentially decrease your risk of getting osteoarthritis, or limiting inflammation on the back end to decrease your symptoms, limit your pain, and increase your function. Other kind of standard non-surgical treatment options I get asked about, which I think can also be beneficial. Certainly heat, that's a temporary thing, but many people find their arthritic pain is worse in the cold. Joints get stiffer, more painful, so heat can help. Sometimes that means a heating pad at home, heated gloves, just kind of depends on where you're getting your osteoarthritis or your arthritic pain. Activity modification is something we talk about and can be hard to do, but for many patients, they are able to manage their arthritis and arthritic pain by avoiding certain activities. Now, a lot of that comes down to your occupation, your preferred activities, but potentially that can limit quite a bit of your symptoms. Compression can help, I think, as a combination of providing some heat as well as potentially just some localized kind of pressure and comfort. So various compression sleeves, again, depending on knees, hips, hands, where we're talking about your arthritis, can help. There are lots of topical over-the-counter pain and anti-inflammatory gels, many of which do have some data suggesting they decrease arthritic pain. So Arnica, CBD, Salon Pause, things like BioFreeze and Aspercreme, I think all of these can be beneficial. In general, I think they're safe. They don't have quite the same, regulations or safety profile as some of the prescription or other medications that we've talked about, but I think in general they're safe and potentially beneficial for at least short-term pain relief of arthritic pain. So what about surgery? We won't touch on this too much. Again, the goal was kind of to address potential non-surgical options. There are a fair number of studies, especially in knee osteoarthritis and hip arthritis, that potentially surgery is more beneficial than non-surgical treatment. And a lot of that is a patient decision. But here was a large study that looked at basically total knee replacement versus non-surgical treatment for knee osteoarthritis. And at 2 years, if we look down here at the bottom, about 50% of patients improved in both groups. So both groups obtained improvement in pain and function. There's about twice the improvement in pain and function with surgery compared to non-surgical treatment. So at some point, surgery is the best option, is right for patients. So my general recommendations, kind of have gone through some various options. I talk to patients that a lot of this is kind of finding what works for you. And what works for one patient may not work for your friends, your neighbor, your spouse. So sometimes it's trying different things for these non-surgical options, especially like the topical pain relief creams. I do think when you come to your physician, especially an orthopedic surgeon, we try to do shared decision-making, getting back to that evidence-based medicine. We use the best available research and data that we have. We use our own clinical expertise, and then we talk to the patient and find out what your goals are. Some patients' goals are simply pain relief. Some are functional improvement. Some patients want to get back to a certain activity, and treatment is really kind of dictated by those goals. We want that treatment to be patient-specific and specific to your goals. In general, and vast majority of patients do, I think you should at least attempt some non-surgical treatment and find what works for you. Many of these things, like the Nsaids, may not be appropriate or feasible for patients if you're already taking anticoagulation. We talked about steroid injections. Diabetics may want to be careful with steroid injections, but certainly there are options. For most patients, there are at least some non-surgical options that can be attempted. And then consider nutrition and diet changes. I think that, again, that data is there. It's not as overwhelming as we would like, but certainly there is some suggestion that various nutritional diet changes may limit your inflammation and limit your symptoms and put you at overall lower risk of having symptomatic osteoarthritis. So additional resources, Jamie mentioned our website. I think we have a fantastic website. You can go through by physician, by specific joint, by symptom, and kind of read through these webinars, various other articles, tips, and things like that. We have a couple of various societies. The second one there, orthoinfo.aaos, that is our American Association of Orthopedic Surgeons. They have a great website for general patient information. Me as a hand and upper extremity surgeon, we have a great website on the ASSH, hand care, that goes through many, not just arthritis, but many hand and upper extremity conditions, good information for patients, treatment options, and kind of things, what to expect. Regarding nutrition, I've used this website a lot, nutritionfacts.org. He's a PhD nutritionist who is definitely kind of more in line with limiting, meat and dairy and more of a vegetarian type vegan diet, which may or may not be best for all patients, but his website goes through various nutritional studies. He'll try to summarize them and give you kind of the best information based on those. And you can also even search by diagnoses like osteoarthritis and see what potential treatment options there are. So I think that's overall a pretty good website that seems to use good kind of research, evidence-based medicine, potentially can be beneficial. Certainly you can talk to your primary care provider. If you're more interested in potential nutritional changes, there are licensed nutritionists. You can do some of your own website research on the website. But that covers some good resources. So we'll try to get to some of the questions. You know, the other thing I'll just add is, again, as I said, I'm kind of a hand and upper extremity surgeon. More than happy to evaluate and talk through options for people with hand and upper extremity arthritis. We have fantastic surgeons in our practice that also do, whether we're talking spinal arthritis, hip arthritis, knee arthritis, shoulder arthritis, foot arthritis. We're happy to welcome anybody to come in and talk about options.